A truly complex case, sad case, a lot of teaching points. We are screening women starting at age 40, but she is 39. 1 year before she would have received the letter of invitation, she found a hard lump high up in the axillary tail of her left breast. Clinical breast examination confirmed the presence of a 1.5 centimeter hard lump suspicious for malignancy. You can take it as a very good practical advice. Palpable carcinoma in women under 40, poorly differentiated and multifocal. This is what you have as a working hypothesis in the back of your mind. And let's look at the mammogram. The mammograms show very dense fibroglandular tissue. It starts to involute already, the indication that in 15, 20 years from now, she might have entirely fatty replaced breast. But the question is, where is the palpable tumor? The lead mark is here. But I don't see any abnormality on the MLO projection, and I don't see any abnormality on the CC projection either. Here there is a low-density circular lesion with these calcifications. We are going to get back to that finding because this is more important now. Microfocus magnification. No mammographic abnormality whatsoever. We need another method. Let's get help from ultrasound. Starting with the automated breast ultrasound, quite peripheral, corresponding to the axillary tail, we see a very persistent and ever-increasing size tissue defect. And when you put the cursor there, you got this picture, you got this picture, and you say this is going to be a carcinoma. Handheld ultrasound confirms the finding. Ultrasound-guided 14-gauge core biopsy proves that this is a very cellular invasive carcinoma. MR examination partly points out something in the right breast, oval-shaped, very much possibly fibroadenoma. But this is the more important finding. High up in the axillary tail. Is this unifocal? Is this multifocal? Keep in mind, you are really looking for multifocality. This would be the right breast. Ultrasound. Ultrasound-guided core biopsy, fibroadenoma. No problem. Now we have confirmed the diagnosis. Let's go back to the left breast. Surgical removal of this amount of tissue, without and with magnification the specimen, ultrasound specimen examination, at least one focus has been removed. Now the slices come. Slice 1, 2, 3, and we take X-ray of the slices. And we examine slice after slice. Slice number 1 has a little tumor here. On the large format 3D histopathology, the cancer is here. This is a carcinoma. Ill-defined, lobulated, with a little comet tail. Here is the intermediate power histology image. Slice number 2. That corresponds to the ABUS finding, 3D pathology. Very interesting picture. There are 3 cancers here, 1 and 2, and they are interconnected with a DAB. And there is a 3rd cancer as well, and that is this. 3 invasive carcinomas as well as ductal adenocarcinoma of the breast, that is, cancer cell accumulation in major lactiferous ducts. Indeed, she has multifocal carcinoma. A little bit closer look at slice 2, which had these different foci, low power subgross 3D histopathology, low power large format thin section histology, great correlation between mammography and the modern histopathologic workup. One more close-up. Here is something that is frequently called incytocarcinoma, but it's not. It's a neoducgenesis. Here we can study intratumor heterogeneity. Although the tumor is relatively small, it has different clones. And this is not a good news. We find duct-forming invasive carcinoma. This is called in situ, but it's actually neoducgenesis. DAB. Micropapillary tumor growth pattern, solid tumor growth pattern, with necrosis. She has very extensive disease. No wonder that she has axillary lymph node metastases. So the final histopathology unfortunately confirms our experience gained during many decades. Younger than 40-year-old women with palpable carcinoma, poorly differentiated cancer that is multifocal. That's why their long-term outcome is poor. The individual foci measured 13 by 10, 12 by 8, 3 by 3 millimeter. I consider this a big problem, the grade 2 and the grade 3 in situ carcinoma associated in such a large area. No wonder that 4 out of the surgically removed axillary lymph nodes had metastasis. Once again, I just have to express my disappointment in the biomarkers. I don't know why clinicians trust them so much. It's an ER positive, PR positive, HER2 negative, relatively low proliferation index carcinoma. So we have several teaching points here. Women with multifocal breast cancer have a poorer long-term survival than women with unifocal carcinoma. That's why we have to perform MR on every breast cancer case to distinguish the unifocal from the multifocal and the diffuse cancer, and to describe the true extent of the disease. So the radiologist has 3 tasks: screen, to find abnormalities, but screening is not diagnosis. So you have to call her back, use the multimodality approach to arrive at a diagnosis. But that's not good enough. We really have to say something about the extent of the disease, because that is going to have tremendous influence on treatment planning, and also on the long-term outcome.